the ways of interacting that we have on a really nicely dichotomized view of healthcare, that you've got health and you've got mental health, and they're different, and your body is different from your mind. And if we think about those differently, or if we act as if they are not separate, you end up with the roles that you would use to address people's needs changing, and you're thinking about them changing. And so it throws up the question of what's the training that people need into the, it throws that into question, and it does certainly makes us have to both rethink the structure of disciplinary structure and licensing structure, but it also makes the disciplines need to rethink some of what they've been doing. And they're starting to notice. I mean, all of the leaders in integrated care are affiliated with one or another discipline. So they're psychiatrists or social workers or psychologists or marriage and family therapists or family doctors. And they're all loyal members of their discipline, but it doesn't mean that their discipline notices what's going on. And I think it's fair to say the disciplines are just starting to notice. And so when the people who do the training first look at things as changing, the question is that really quality, what you guys are doing? This generalist stuff that you do, it's not like specialty stuff. In specialty stuff, we go into stuff deeper, and we're trained to spend more time with people and to approach certain diseases or certain conditions with evidence-based approaches for that specific condition. And here you are doing this generalist kind of approach with people who have a lot of things lumped together, and it doesn't feel like quality work sometimes at first. And so, and the last one, I don't know if that's fair, but I said they're trying to put their feet on as many bananas as possible. You know how, I don't know if you know how, but in the zoo, if you go to, nowadays, everybody, all the big apes are out in some kind of pasture, but in the old days, they'd be in a cage. And when they would throw the bananas in there, the lead monkey would go and get near the bananas and pick up the ones he could eat and put his feet on the rest of them. And it wasn't like he could eat them. He was just going to say, these are my bananas. And that has been a way in my family that we've talked about, sort of trying to spread your influence as far as you can. And so I go to meetings in which people from one discipline or another, and I tend more to go to psychology meetings, say something about how can you do this unless you have one of ours there? This isn't really quality work unless we are central to it. And so I think that competition that's left over from past era is going to be hard, and that there's still some tough times ahead because of that. On the other hand, people who work in primary care tend to not worry about discipline so much because your team member of whatever discipline, when they help you out, it's much more collegial than I was used to when I worked in mental health settings only. So what can we do? Well, I hope after today you feel like you have more awareness of the problem, and I think you probably already have a substantial awareness yourself, that we're open to thinking differently, that we see thinking differently as a value, that we assess our own training, because each of us has gaps. Nobody comes to this work fully prepared, or at least very few do, because we were all trained for some other kind of work, for specialty kind of work, or for something other than integrated care. And that you that you're willing to push for funding for primary care training whenever you're pushing for new clinical models. One of the things I find is we say, okay, we're going to try and get integrated care as a part of the new Medicaid payment transformation here, and at the last minute it occurred to some of us, oh, well, we've got to be sure that this approach values training and uses itself to train the next generation, because historically most of the funders of care have not wanted to be responsible for the next generation and have not wanted to fund training in clinical settings. And so we all end up advocating in all directions. You really can't be in integrated care in this country right now yet without being an advocate. You end up always looking for things to change and evolve to make this work. So let's talk a little bit about the categories of relationship in integrated care that we're preparing people to do. This is one way of defining it. Other people have other ways, but if you don't mind, we'll use mine. And that is coordinated care, which is behavioral services by referral in a separate location. Co-located, which is by referral in the medical location. So somebody is, a behavioral health person is in the medical location, but is taking people as referred by the physicians. It is a separate service located together, and then integrated, in which the behavioral health is part of the medical treatment. There's one treatment plan, and it has medical and behavioral aspects. So what would be the basics for coordinated care? Well, you would need at least, if you're going to call it coordinated, appointment arrival notification. If one side, usually the medical side, refers someone to the behavioral health side, they need to know that you got there. They're going to be required to show that they got there under new PCMH regulations at some point. And so the exchange of just the knowledge that people are in treatment and where they're in treatment, which is the coordination of information for care, coordination of care, is inevitable and necessary. There needs to be protocols for exchanging information. Information exchange is a hot topic when people first come into this field, and they need to have gotten that solved and not be trying to solve it at each particular case that comes out. And there needs to be the ability to do coordinated treatment planning, at least in some cases, at least in difficult situations. And if you would be calling someone's therapist or someone's physician and asking for a meeting, and they had never had one before and never thought of it, then I wouldn't call what you had coordinated care. For people in the behavioral health world, it's important that they expect communication to go both ways. That it's not just that we tell the medical folks that we've got somebody in treatment and give them a couple of bullets on how it's going. It's that we know what the person's medical needs are, and that we think of ourselves as a member of the healthcare team, so that we ask the person about their diabetes and how it's going with that, and what their understanding is about any changes they need to make in relation to their asthma and so forth. So that, and that the person's health behavior goals are part of treatment planning. Often the connections that are coordinated are best done when the specialty setting is a consultant to the generalist setting. So in Massachusetts, if you're a primary care doctor, and you have a child that you need consultation about in terms of, for instance, medication for ADHD, you can get a child psychiatrist on the phone in half an hour. That's a program that's made possible because of the focus on coordination and on consultation, rather than on sending all the kids for treatment somewhere because it doesn't work. The other treatments fill up and they clog up, and nobody can get help. Co-located. Well, the evidence says that when you have those two together, you do get better access, significantly better access. We'll talk about that more in a minute. Patient satisfaction goes up. The provider satisfaction goes up noticeably. In some settings, provider retention, keeping the doctors working, went up. The cost effectiveness is good. Clinical outcome is good. The problems with co-located care is unless you've worked it out to do really brief kinds of interventions, the fact that it's a referral rather than part of the same connection or same care means that people make a decision about whether to accept the referral, even though it's in the same site. And so often they don't go. And if they do go, and you see them like you would in a mental health center, you see them for an hour, and you see them 7 or 8 or 10 times, your caseload is going to fill up, and suddenly you have a 3-month waiting period or a 3-week waiting period internally, which is just as bad as having it externally. And so many programs have failed because the behavioral health people practiced in primary care the way they practiced in their specialty setting. That doesn't mean that you couldn't have primary care behavioral health and people doing specialty type mental health work also in the same building, but that the primary care part needs to be much briefer. Here's an example of one of the two sorts of integrated programs that have been evidence-based and that are spreading around the country. It's called the IMPACT model. It comes out of the University of Washington, and it grew out of original research on integrated care management for depression. And so at this point now, the care manager has become a depression clinical specialist. It's a person, often a psychologist or a clinical social worker, who does patient education, symptom and side effect tracking, and brief therapy. And brief therapy can be up to 6 to 8 sessions, and in consultation with the primary care doc and backed up by a team psychiatrist. That patient education and symptom and side effect tracking, which is another way of saying you're the eyes and ears for the care team, has proved to be very effective. Here's the red is usual care, and usual care also has as an option going to mental health treatment somewhere else. And the yellow is the impact approach, which is about twice as effective and is much more durable in its effectiveness. It's 3 months, 6 months, and a year there. Then there's the behavioral health consultant model. This picture, by the way, where it says BHC, that flag, that's from Cherokee Health Systems in Knoxville. And that's what they actually have there. When the doctor comes out of an exam room, they can put out the BHC flag, and it will remind the nurses to get the behavioral health consultant to come in and be a part of the care. There's somebody there who's available right that minute, or right that in a reasonable amount of time, who's can be brought in to do a consult and help develop or implement a care plan. And so and the behavioral health consultant is somebody who is consulting to the physician and to the patient. And that consultation can involve brief kinds of intervention, but it doesn't involve doing any kind of longer-term therapy. Just as a quick understanding of the behavioral health need to connected or in relation to primary care, if you have the whole system, Cherokee Health Systems is both a federally qualified health center system that has multiple sites, and a community mental health center. So it does both. It does not need to refer outside itself for specialty mental health. And when you look at that whole system, what you see in terms of the numbers of people needed to do this work is that it's, primary care docs, there's 48 providers for 40 psychologists and 60 master's level clinicians and 20 psychiatrists and 30 case managers. It's a highly behavioral health loaded system, and people might say, well, gee, that's awfully expensive, isn't it? This is the numbers for Cherokee that was given to them by Blue Cross in their area. And it compares their level of utilization with the other regional health systems. And what they find is that the utilization in primary care is significantly higher, but that the costs, both in ER visits, specialty care, hospital care, and the overall costs are significantly lower. When you match the array of providers to the actual patient need, you end up with a very different looking health system, and you end up with lower cost. So these models, let's put them together, compare them. On the left is the impact model, and on the right is the behavioral health consultant model. The impact model was disease-based. It comes from originally studies of treatment of depression only, and then of depression and sometimes other illnesses like diabetes. Whereas the behavioral health consultant model is program-based. How do we get behavioral health into a primary care practice as broadly and as thoroughly as possible? Impact has a research heritage. Behavioral health consultant model has a clinical heritage. That means the impact folks can show better patient outcome because they were created as a study. However, the behavioral health consultant model shows better cost and satisfaction evidence. The provider person in the impact model is called a care manager and is a social worker or as a psychologist. The provider person behavioral health consultant model is called behavioral health consultant and is usually a social worker or a psychologist. And in some ways, they're beginning to converge, because if you talk to the leader of the impact model, that's my friend Jürgen Unitzer, he will say, in primary care, you also need to have care for life problems and crises, not just for depression or anxiety, or not just in these kind of narrow programs. He will say you have to address the needs that people bring. And if you go to Cherokee, for instance, where they have a behavioral health consultant model, they have targeted approaches to particularly high need groups, and keep registries, and are taking in the targeted approaches that people have been using in the impact model. So they are converging, these two separate models. And they're converging, and at the time when the patient-centered medical home, some people want to call it a health home, I don't want to argue it, but the medical home language is more common, at least in the primary care world where I live. And the patient-centered medical home is offering team-based care, proactive population management. In other words, you have a registry, you look at everybody in your practice who has a certain problem or illness, and you reach out to address their care and make sure they get care rather than just wait to see who comes in. That you're working to improve all the time based on data, that you are clearer about what your workflows and your practices and your regular ways of doing are, and then you make adjustments, because since you're clear about what you do, you can be clear about what kind of changes you're going to try when the data say you need to do that. And payment for health rather than just for service. Now, behavioral health is becoming a part of the core set of services for the PCMH. One reason is because of access. Steve Bartles and his group did a study in which they compared the treatment for depressed elderly folks, and one arm of the treatment was people who the people were randomized into the two arms, and one random arm was referred to a mental health center, and one random arm saw people in the primary care practice. It was the same clinicians. So the clinicians were in two places, depending on which group, and so that people got the same treatment in both places. And in the referral side, they called it enhanced referral because they would not only make the appointment for a patient, they would give them a ride to the appointment. They would do anything. They would solve any problem that was involved in keeping the person from getting to the specialty site. And what they found was that even when you solved every problem involved in referral, you get 50% better uptake of people initiating care just by putting the services in the primary care location. And if you're going to be held accountable for delivering the service, as the PCMH is going to do, you have to do what you can do to make sure that it's going to be used, because nobody makes people use it. Then there's also more approaching or more emphasis now on chronic patients, or complex patients, I mean, with chronic illnesses, a lot of behavioral health needs, high utilizing, high cost people. And those folks are the ones who get medical home level of care. They're also people with substantial behavioral health needs in almost every case, whether or not the behavioral health need is the headline, is the topic sentence of their situation. Behavioral health in primary care is a much better cultural fit for a number of people. When behavioral health folks are part of the flow of care, as I witnessed at Cherokee, they save time for the primary care physicians, because the primary care physician can leave things to be addressed by the BHC. And care management for depression, which is part of many of the patient-centered medical homes, is more effective when done by people with behavioral health skills. You can't just send somebody in there to do that who isn't trained to do behavioral health kinds of things. And this is what NCQA is saying you have to do. I'm not going to read it to you, but you are going to have to do this to be a level 3 medical home, and they're updating it all the time. And it's just going toward more and more integration required. And so when you get to health being the issue, are you delivering health to people? It turns out that for any of the conditions, asthma, diabetes, cardiovascular disease, depression, obesity, substance abuse, any of the conditions that are likely to be target conditions, health behavior is a major or the major issue. And so the expertise in health behavior becomes crucial for the PCMH. And the PCMH is the building block for the Accountable Care Organization. The Accountable Care Organization is a larger health system that is responsible for the outcomes and the quality and the costs of the patients they're dealing with. Like in Massachusetts, where we have a PCMH ACO program called the Massachusetts Primary Care Payment Reform Initiative, and practices will be paid per member per month rather than on fee-for-service, based on the level of behavioral health they can deliver. And I'd love to talk to you more about that. I was part of the group that helped write those that situation, or that model. So I said, okay, it's coming. Can't we just assign the workforce we have? Mental health and substance abuse professionals want to do specialty care. What we're saying is it's hard to, the workforce we have has been trained for a different set of services. And so if they are not immediately comfortable in this new set of services, it's not a reflection on them. It is inevitable that people might not be comfortable. And so mental health care managers, case managers tend to have little experience working with health issues. Although they're very good at working with behavioral issues. Medical care managers who have been around forever have been shown, actually there's a literature now on nurses who are care managers dealing with depressed patients, and the literature says it makes them uncomfortable and it makes them not like their jobs if they haven't had training to work with depressed people. We have a medical system that's built around the idea that we tell people what to do and that they do it. And we call it giving advice, and we give them very good advice, and they don't do it. And before we could say, well, that's his opinion, that's his problem. I gave him the best possible advice and he didn't do it. I'm really too bad, but that's up to him. And now if we're going to be accountable for people's health, we have to find a way to engage them and activate them and make them part of the team, and hardly any of us are good at that. It is a whole transformation in approach that is going to be very difficult, but behavioral health people tend to be better at it. Not that they're all good at it, because they're not, but they tend to be better at it, and it tends to be a skill that they can be helpful with in primary care. So primary care is difficult for people trained for specialty mental health. The people are less disturbed and less diagnostically clear. There's all of these different needs. People often come out of the mental health world thinking about the competition between the disciplines, and they, I don't know about all the disciplines, but certainly psychology is really prickly about whether or not we're as good as physicians. And I know that social workers are sometimes prickly about whether or not they're as good as other disciplines. And so everybody's prickly. And in primary care, the issue is, who is the team that the patient wants to work with? The patient comes to see their doctor. They don't come to see their psychologist usually, certainly not at the start. They don't come to see their clinical social worker. They come to see their doctor. And so we end up needing to be part of that team in a way that's helpful. On the other hand, you will never be as appreciated in the mental health world by your colleagues as you will be in primary care, because you will be saving your colleagues' tail by dealing with a problem that the primary care doc really doesn't know how to deal with, like somebody crying, for instance. And so there's a good deal of exchange that is very positive between the disciplines in primary care. And there's different routines of time. It's quicker, of confidentiality. You're on the team and you're all sharing information. And instrumentality. We're going to get something done today. Not just going to shake hands and say, I'll see you next Tuesday. I'm going to teach you to put yourself to sleep. I'm going to teach you to breathe in a way that will reduce your anxiety. I'm going to do something for you today, and that's part of how I'm going to engage you in working with me. But it also means that the next time we meet, even though I only spent 20 minutes with you today, it'll be follow-up. It's not going to be this long, complex assessment. It's going to be, look, we already started something. Let's see how it's working. Do we need to adjust it? And so it means that as a generalist clinician, you have to have a pretty substantial array of skills here. Care management, brief therapy, behavioral medicine kinds of things, health behavior change, families, substance abuse counseling, child development if you're working with kids, psychotropic medication input, both an input for the physician, not necessarily. I don't tell physicians what to prescribe. I'd really try and stay out of that. If I had had the training that some psychologists get, I would be comfortable doing that, but I have not. But I am very comfortable saying I think you might want to consider medication for this person. I'm very comfortable saying I think you might want to consider increasing or decreasing medication with this person, or these are side effects that I'm seeing. I think you might want to consider rethinking this medicine. And I'm certainly very comfortable saying to the patient, help them think about the role of medication in their life, because that's often a hard one for patients. And so we also do groups and patient education, community outreach, organizational transformation agent. And I say that because you can't work in primary care as a behavioral health person without changing the whole practice. And so you just have to be comfortable with it. And so it's often about the person. You need to be good at making relationships. You need to be good in ambiguous situations to dive in rather than waiting for an invitation. If you need to know that you're doing the right thing all the time and to wait to be told that you're doing the right thing, you probably are not going to be comfortable. So on the other hand, if you are somebody who likes to go deeply into a person's experience and make a long-term connection with patients, and the idea of all this change in primary care seems to you like a terrible idea, I hope nobody ever tries to make you go into primary care, because we need both kinds of people. It's not like everybody ought to be primary care behavioral health. And the role of psychiatry, I'm not going to go into this deeply. We already talked about it in another slide. But basically, primary care needs psychiatrists, and they need psychiatrists as consultants and as helpers, not as people that we refer everybody to. And there are psychiatrists who are getting that, who become really so valuable to primary care docs and so appreciated. And then we need care managers too. Somebody's got to reach out and actively engage patients even when they don't come in. Someone's got to look at the transitions of care and be able to address barriers to access. How do we get this person a ride? How do we get this person able to be retrained after their injury? All of those kinds of things need to be someone who can reach out and do that, and it's particularly true for the most complex patients who often have very limited ways of solving things that get them back over and over again into the ER, or make them have difficulty or in compliance or adherence that put them at risk. And so if that's the way it's going to be, it means we need to rethink this whole thing about disciplines. I mean, depression care managers, just as that one role, has been MSWs, nurses, psychologists, NPs, and PAs, and they have all been good fits. At least some of them have. When people say, do you want a social worker for that job, or do you want a psychologist? I always say, which social worker? Which psychologist? Because it isn't about the discipline, it's about the skills. And I think that it's important to highlight that these are modular skills. People already come with skills that are quite relevant, but they need to add new ones. And those ones tend to be modular, can be identified. And so how do the roles interact on the team? Behavioral health consultant types tend to have broader array of involvement than care managers for complex patients. They tend to have to deal with a whole bunch of different things. That doesn't mean they have to be just surface, because they have to be very skilled in a number of things, but at a generalist level. Care managers and coordinators are often, or care coordinators are often directed at fewer but more complex patients, more intensive contact, more outreach to solve problems in the community. I read a post from Jeff Ryder today that I found very helpful, because we're always talking about workflows and how do we design workflows, and he said, you got to remember that patients often don't want the workflows that we develop, and that letting the patient decide around issues of, are you going to have a care manager, care coordinator, are you going to be involved with a behavioral health consultant or clinician, all of those, the fudge factor from a systems perspective is the patient, but the patient isn't just a fudge factor, they're the one we're doing it for. And so we got to keep that in mind. Historically, the idea has been that the patients had to have a nurse, the complex patients, because they have scary diseases a lot of times. But it's not proving to be as good a fit for many of these complex people, because it turns out that it's their behavioral health issues that keep them from getting better, from connecting with the medical system. And so in a lot of settings, it's the behavioral health consultant who is the regular supervisor of the care coordinator or care manager in order to keep that behavioral health skills and give the behavioral health backup for the care managers, but they're also working closely with the physician. So if you're not a medical person, you have to have enough training to competently be the eyes and ears of a medical treatment team. And then it's worth remembering that as you broaden care management as a concept to more and more people, it really becomes a role, not a job description. I mean, my doctor is my care manager because he is the one who tells me how to connect with people, solves my problems that I have in getting the care I need. But I'm a pretty competent consumer, and so I don't have many of those problems. But that it is, care management is a role that many different people on the team might fill. Who trains the workforce for integration? Well, one place is at the Center for Integrated Primary Care. We train folks. We have a certificate program in primary care behavioral health. We train people to be behavioral health clinicians or behavioral health consultants. In primary care, we have a certificate program for integrated care management and an intensive training for motivational interviewing. There are also good programs at the Ames Center at the University of Washington, at Farley Dickinson University, and Arizona State has a doctorate in primary care behavioral health, although that doesn't get you a license to practice. You have to have a license to practice someplace else. And so here's my last slide that sort of shows the heritage of all of these things that are, and at the top there, the behavioral health consultant, depression care manager for complex patients in the patient-centered medical home, and care coordinator in integrated health systems. And integrated health systems means the whole system is connected. It doesn't mean integrated behavioral health into primary care. These are the sort of the heritages of these roles. And the top four folks there are often the role sits between somewhere, one of those boxes. And so you see in our training program, our primary care behavioral health certificate is for behavioral health consultants and people who are going to do depression care management in primary care. But our certificate in integrated care management is for people who might be the depression care manager as well as the care manager for complex patients in the PCMH. So back to the idea that these are in flux, and we're doing our best to be clear about it, and we know a good deal about the transformation from where people came from that's required to get into doing this, but we don't have a good idea of exactly how this is going to be developing in the next few years. And with that, I will take questions.
So our first question is, should care managers be nurses or mental health professionals?
And my answer is, it depends on the population. In general, people overestimate the need for nurses because most of the people, the complex patients, have serious chronic illnesses. But that doesn't mean that some people with chronic illnesses don't need a nurse. And so that's really the best I can say. In places where outpatient settings, not inpatient settings, I see a strong drift toward social workers as the care managers, but they have to be social workers who are comfortable with discussing diabetes and someone's eating and someone's A1C or the whole issue of asthma triggers. All of those things have got to be part of the skill set. And so just sending a social worker who isn't going to talk about their chronic illness is not going to work. And so when we're training people in our integrated care management program, we're assuming that we're training some people who are medical people to be much more skilled at behavioral health, and some people who come from the mental health world to be more skilled at health behavior and health generally, and at working with physicians.
Thank you. And our next question is, how do you foresee our training programs changing in light of the vision you have laid out for us today? It seems that there needs to be some fundamental changes in our training programs to achieve true integration.
I'm not sure what our training program means. It means all training in the U.S.? Is that what that means? I'm not sure what.
I think you could take it as that.
Okay. Well, calling for fundamental change in something as big and as set as training programs for mental health in the United States is fun to do. It makes you feel like a prophet, but it doesn't get you very far. So yeah, I would love to see what I would like to see in psychology, for instance, is the assumption that everybody gets exposed to primary care and to the generalist specialist dichotomy in their training, and they get the idea, and that people who like that and find that as a enjoyable fit then have a career track that they can follow to get into primary care. That they will have clinical sites that they can go to and ways that they can move into that work. In general, what happens is that in the disciplines, when you say, we want to add something, people tend to say, yeah, but what we have is all important. We can't give up anything. I'm sorry. And so I'm hoping that there'll be some rethinking of that, and that the urgency will seem so substantial that people will be willing to say, okay, we're going to find a way that some of the folks can follow this path, even though it's not a path for everybody.
All right, and next for you, Dr. Blount, we have, what general behavioral health enhancement skills are most important for primary care providers to possess when working in integrated care?
Well, I've got 36 hours on that I could do. So, general skills. Well, one of the general skills is you have to be, like I said, really good at making connections pretty quickly, comfortable getting started and being problem focused. I think you need to be able to do brief, targeted kinds of interventions. I think if you are trained as a more reflective kind of therapist, it probably won't be a fit, and you'll be more comfortable, and you'll do better if you have something where you can help people take action, do things to make their lives better. On the other hand, you have to have your ear open for a time when you need to shut up and listen, and be the one on the team who goes more deeply into where these difficulties come from. Um, you got to be comfortable with understanding illnesses, chronic illness, and um, well, and be able to intervene on the body with words. That's the relaxation response part. Um, and I think you need to be comfortable with families and with groups. Interviewing more than one person. Often the physician is not comfortable with that, and so you're the one who can do that. So that one slide where I said generalist behavioral health clinician, that slide is a pretty good summary of the things that I think people ought to be able to do.
Great. So our next question is about the role of substance abuse treatment in this new paradigm shift. What is the standard for the level of credentials necessary for the integration of substance abuse treatment in the primary care model?
Um, the level of credential is an interesting way of saying it. The as opposed to the level of skill. Remember I talked about modules, that these skills are modular. If you're not ready to do substance abuse care, at least on a generalist level, and that means set up screening and help with identification and make liaison with specialty care and support motivational kinds of interventions, be able to do SBIRT approaches, do competent 12-step facilitation, understand about medical approaches to substance abuse. All of those are basically part of the deal. It isn't necessarily that it should be a credential, because you're not going to have a credential for doing anxiety treatment. You're not going to have a credential for doing relaxation response treatment, or at least I hope you don't have to. See, that's the thing. Each little area wants to say, unless they have our kind of specialty training, they're not really competent, and we can't really trust them. And I'm saying, no, as a generalist approach, there's modules that people can have, and we could have, if you have something that's modular and that people can do as part of their training once they're on the job, I think that that's great. And they ought to be improving all the time. They ought to be, continuing to sharpen their skills. But I don't know what the credential should be to do substance abuse care.
Okay, and before we get to our final question, I'd just like to remind all of our participants that a recording of this webinar will be posted onto the Collaborative Family Healthcare Association's website, and that is www.cfha.net. And so the final question for you, Dr. Blount, is, are there any national conferences that address integration that people could attend?
Well, that was a plant. Yes, there is. There's the CFHA conference. That's a really good one. I'll be there, and so will everybody who's been involved in and excited about integrated care, or at least a lot of them. It is in October. This year it's in Denver. There are a number of others, though, that are getting better. So if you look at your disciplinary conferences, there may be a few presentations on integration. And the other thing is that the disciplines need to be pushed to talk about integration more and understand it better. And so if you write a letter to the conference committee of your discipline, whatever it is, and say, what are you going to do on integration at the next national or regional conference? And we really ought to get some people who are good at this to be part of our conference. I think they would like to hear that.
Great. Well, thank you again for the wonderful webinar, Dr. Blount, and thank you everyone for logging on and participating. And once you close out a screen, a brief evaluation will pop up, and we would really appreciate you taking a few seconds to fill that out.
Okay,
Our
and
next,
I
oh,
put my email address on the last slide if people can still see it. I don't know if they can, and people can contact me, and there's the website of the center as well.
yep, everyone can still see that.
Great.
So thank you again.
Thank you.